very good afternoon to everybody. Thank you very much for joining us. My name is Simon Murnane and I am the Clinical Operations Manager at Ainscoe Associates. I'm very pleased and excited to be hosting today's webinar on the multidisciplinary team and case management. I'll quickly introduce our panel. We've got a very experienced and knowledgeable group of MDT members with us today, which is great. I'll start with Liz Williamson, who is a consultant speech and language therapist at the Speech Group. We've also got Sally Delafontaine, a specialist neurophysiotherapist from Milestones Neuro Rehabilitation Clinic. We've got Martha Turner, who is a consultant clinical psychologist and neuropsychologist at Cognivate Rehab, and Nicola Shalom, who's the clinical manager and specialist neuro-occupational therapist at Chrysalis. So thank you very much to our team for joining us today. So I'll get started with our first question to the panel, if that's okay. And I'd like you to, if you can, describe what you think makes a good MDT, giving an example of a positive experience you have had of working as part of an MDT for a case management client.
Thanks, Simon. Shall I kick off on this one? I suspect we're all going to be saying very similar things actually, but my answers would be, I guess, communication. Obviously, communication is key to working as a good MDT. But the other thing that struck me about this question was that if you're really working as a good MDT, you're working as a team rather than as a collection of individuals. And I think those are the examples when you see MDTs really succeeding. So rather than working, we've got our sort of our physio goals and our OT goals and our SLT goals and our psych goals. I think the really successful MDTs are when we are genuinely working together, because then it's more than the sum of its parts. I think we all work better. So I guess it's about that sort of genuinely interdisciplinary, that joined up working when a client brings a goal, and actually our job then is to fit in under that and work out how we help them achieve that with all of us working together. So that really joined up working, I think if you can get an MDT working as a team, it's really powerful and gets much more and much better results than sort of individuals. Sally, we may have the same example. I was trying to think of a good example of this, and it's actually a case that Sally and I have worked on together, which is straightforward in some ways, but it was a client who had physical difficulties which were impacting his walking, but also had PTSD. And his goal was to be able to reach his local shops, his cafes, his, all of these things again. And neither of us could have worked on that alone. I couldn't have worked on the PTSD without Sally. Sally, I hope I'm not overstating it to say that it would have been difficult to work on his walking without the PTSD side, but together we were able to get a lot more, I think, than either of us would have been. Yeah,
and just to interrupt, Martha, I'm thinking of the same client where sometimes there is an overlap. So, we have to work together potentially jointly, even if it's for a few sessions. And actually that enables the client to get it, because often, nobody works in isolation. So the impact of anxiety, for instance, on vestibular dysfunction, and with particularly this client. So we had to build up his stamina first so that we knew he could physically cope, and that helped his disorientation. And then we could then address the anxiety in the environment where it really became a problem. So yeah, a good MDT is where you recognize how you need to perhaps collaborate and work and overlap and recognize each other's skills and not be frightened of actually this sort of cross fertilization of ideas and not getting territorial about what we do, because actually with brain injury particularly, it's so interwoven. So I don't know if Liz or Nicola want to add anything.
I think I just to add there, because I agree, Martha, sort of communication is obviously key here, and I think we're all agreed. Just thinking about communication, what makes a good MDT is to really establish your lines of communication. So how are we going to communicate as a team? Because I think if the expectations and the understanding is there, I think that makes the communication flow much easier and to work much better as a team, rather than one of you expecting one level of communication and someone expecting something else. And I think just the joint goals on the back of that is really great. I think we all, as professionals and clinicians, we all have our own goals that we work along with clients, but to have that joint set of goals makes us really cohesive in the approach that we're taking. That crossover that you're talking about, Sally, with Martha, and that's where that pulls in, isn't it? Because actually there's 2 or 3 of us that might be working on one specific goal of the clients, not necessarily just in isolation. We can work in isolation on some things, but there's lots and lots of things that we work on together.
Completely.
I totally agree with my fellow colleagues here. I think the word goal is an interesting thing to consider, because some of our patients or clients, they select goals based on their value set, and that we as clinicians have to be aware of those client values and how those goals come from those values. And sometimes our patients do need help with devising their goals or kind of understanding their own value set. I had an interesting conversation with a neuropsych yesterday. These conversations are vital in this process, and they're often not conversations had in a formal multidisciplinary meeting. They're often just pick the phone up moments, or that corridor conversation they call it. And this conversation was so vital in us agreeing that ultimately this client probably will engage in a managed failure of that goal. So even though that their goal is to achieve, say, going back to work or getting B's in their GCSEs or something, we can sometimes forecast potentially this goal may not succeed, but certainly in insight raising tasks there can be an engagement in a type of managed failure, which I found a really interesting concept to engage in. So it's often not as simple as it sounds in setting goals. So that's what I have to add to that.
I agree, Liz, and I think also as well, we at Chrysalis, we have a very with our own sort of goal setting format, we very much look at the client's voice verbatim. So what are they actually saying? What is their actual goal, not our interpretation of it? But equally, what's really important from that is that actually some of those goals might not be realistic. Some of those goals might not be achievable, but it's really important to hear what's based on their value system and what's important to them.
Yes.
You'll be unsurprised to hear that I completely agree as well about the values of it. And I think most often where we go wrong, if we find that we're not progressing on a goal, it's nearly always because we've ended up working on our goal instead of the client's goal.
Yes.
And I think that's so often the case. And getting back to what motivates the client, what is this client's actual value, normally gets you out of those sticky situations.
Agreed.
I think also empowering people, if they're not being heard, as we're all saying, and if they don't feel empowered, if they're not part of that process, then the motivation becomes a real factor. And so, yeah, it is enabling them to, take responsibility and ownership of what they want to achieve for the sustainable future so that we can become redundant.
Very good.
Yeah,
Yes.
that's really interesting, and I think it leads into my next question I'll ask in a minute around our clients' involvement in their process. But I just one point I forgot to mention at the start. We are taking questions from the audience, so if anybody does have any questions as we're going through the webinar, there is a Q&A function on the Zoom webinar, so feel free to send those questions through, and we'll get through as many as we can throughout the hour we've got with you. So my next question, or kind of point, I guess, as a case manager, I feel it's absolutely critical and vital that the client is considered an integral part of their MDT and is involved in MDT discussions and meetings and goal planning and reviewing those goals. I think that's absolutely critical from my point of view. So I'd like to ask the panel what your thoughts are on this and ways that you ensure that your clients do engage with their teams. And then the second part of my question is, do you actually feel there are times when it's not appropriate for a client to be involved in those MDT discussions?
I can say something if you like. I think both of those ways of conducting an MDT have value. I think the again, just like it is with goals, is just thinking about what the purpose of that meeting, what is the purpose of that meeting. There are sometimes MDTs that have to potentially happen without the client present or the family present, but then there's other situations where it's very important to evidence through whole team family client meeting that we're all communicating effectively with each other and demonstrating that the things that we're working on. But I'd be interested to hear what my fellow colleagues think. But I do think that there's merit in both types of meetings.
I agree, Liz, there's merit in both, there's value, and you've got to identify the purpose of the meeting. I think with regard to what's been going on over, I know we don't want to talk about COVID, but what's been going on over the pandemic is that a lot of calls now or team meetings, they're really useful to hold on Zoom or Teams or whichever platform, but there are some clients who find that terribly overwhelming, and some who actually can't communicate effectively. They can't maintain their attention, or it's actually triggering symptoms, particularly in my little world of vestibular dysfunction. So I think it's the right forum for the right client at the right time. That's sort of my take on it, but I agree with what you were saying.
Yeah, I think I'd agree as well. I mean, I suppose as a baseline, I think I'm the same as you, Simon, in that wherever possible, I think the client should absolutely be at the centre. This is why we're all there. So they should, wherever possible, they should be involved and supported to be involved to the fullest extent, because otherwise the MDT becomes something slightly separate or disparate, and you run that risk of, we all think we've hit on something wonderful and hit on an understanding or a next step, but if we haven't brought the client along with us, that's likely to be wasted. So yeah, involving them. And the other point I was going to make is that I'd go slightly further and say it's not just the client, it's their entire system. So wherever possible, not always appropriate, but it's the client, their family, their care team, everyone around them, because at best we might be seeing them 1 or 2 hours a week, sometimes more if we're lucky, but that's still a tiny proportion of what's happening in their life. And if the things we're doing are going to make meaningful, lasting change, then it's got to be integrated in the time we're not there as well. So I think involving that whole system is.
I think there's an interesting point here about just reflecting on our last question or our first question about what makes a good MDT. Well, I think what makes a good MDT, if we're being truly client-centered, so that makes the client front and center of our approach, that's what makes a good MDT. But actually, I think we do have to reflect in our world that we are all living in terms of the medico-legal world. Are we completely always truly client-centered, or is there other drivers? Are there other motivations around what is the intervention and that input for the client? And I think that we have to be very aware of that as a team and as professionals working with our client, and what impact that is having on the client's decision making, the client's judgments, the client's influences, and obviously the ripple effect on their community and on their.
Yeah, and I think it's I'm just thinking as the case manager again, and coming back to the point around making sure the client and their system and their entire network as they see fit is involved. One of the first things when I go and meet my client for the first time, because usually I'm seeing them before I'm instructing a team such as yourself, is discussing with them and assisting them to understand the importance of their involvement in that, and that it's not having therapy done to them, which is very old-fashioned and how it used to happen many years ago, but it's their therapy team, it's their MDT, and they're central to that. And the best MDTs from a case manager's point of view always work when the client's engaged, willing to take on feedback from all of the team, and it has to be that open communication system, I think, is absolutely vital. So I think part of my job when I first meet someone is explaining that to them, because that's sometimes very foreign and very new to them. If they've used to being in an old-fashioned model where they've sort of told what to do from a medical or a therapy point of view, and they don't even feel they've had much choice. It's flipping that on its head and saying, actually, you're central to this. Yes, there's possibly some constraints and some pressures around the legal process or funding or all sorts of things that can make it more challenging, but actually that's the central principle as the case manager that I'm trying to portray to my client from day one. And I think if I do that well, it hopefully makes the MDT's job a bit easier once we get you on board. And be interested if anyone's got any thoughts on that. But I think that's a critical job of a case manager to make sure that that client and their system is engaged in that mentality, really.
I think you're absolutely right on that one, is that you're kind of like a go-between, if you like, between the the MDT as a an organism and the client and the litigators or whatever. So I think that we, as, I don't know, I'm sure other people agree, but we rely on that case manager to set that system up so that we can function in that system.
Yeah, completely agree, Liz. And actually, if you think of it from, I mean, obviously all clients come with different expectations, but I would think a fairly normal occurrence is that this is very foreign and quite intimidating, that you've suddenly got a load of professionals who seem to know how this works or are used to doing things in a particular way, but it's brand new for a client. So supporting them to be in charge of it is if the case manager can do that, it's wonderful.
I think your second part of the question, Simon, was about, is there ever any situations whereby the client, it's in their best interest not to be part of that communication? And I think it's true to say, probably for all of us, that we've experienced that around capacity, safeguarding, those kind of issues and needs, whereby we have to think in the client's best interest and to think whether or not that is appropriate for them to be involved. And that's really tricky, because we're making a decision on behalf of somebody else as to whether or not it's in their best interest. And it's hard, we've got complex clients that we're working with, so there's going to be many issues that I'm sure we've all experienced.
Right, just a bit of a similar theme, but some occasionally I've had clients who have full capacity to engage in their process, but they for one reason or other choose to be a fairly inactive member of their team. As somebody with full capacity who's got the ability and the right to make that decision, we have to respect that choice. But I'm just interested in, I'm going to assume you have had those experiences as well, of those kind of clients who are happy to attend and do what they're told, for want of a better term, but don't fully engage as we would maybe see it. And just people's thoughts on your experience of that and ways that you've enabled that to not necessarily change the client's perception or their willingness to engage, but how you still ensure that you're part of a good MDT under those circumstances.
I think you have to, in that situation, examine the barriers. What are the causative factors of that situation arising? For many of our TBI clients, it can be the barrier of insight and cognitive difficulties, which can be very easily masked by behavior. And so in those situations, they're particularly challenging, I would say. And there can sometimes be a real threat to the MDT in a sort of a scattergun approach of trying this and trying that, and then one thing fails and then you pick up another goal or task, which actually has a self-fulfilling prophecy of kind of like the client sitting there going, this is meaningless, nothing is working, nothing, and it just becomes this kind of cyclical problem. So that's been because I work in cognitive communication disorders, this is something I have seen in the past, but I'm not sure what my fellow panelists feel about that.
I've had similar experiences, Liz, so I think there are a million different reasons why someone might want to be slightly less involved, and it's about working out why that is. And sometimes that's completely appropriate, and we just support them to be involved to whatever extent they are comfortable with. But I agree with Liz that in those cases, you need to be really careful that the intervention doesn't drift, or that we don't start going off track, and that we can support the client to whatever extent possible, keep us online and in track with what they actually want, because otherwise it's wasted.
I think it's also getting the message, going back to their goals, and whether the relevant discipline or the case manager needs to go back and talk to the client individually and present the information in a less overwhelming and intimidating way. Because I think sometimes, you know, these calls can be overwhelming on their own. You know, all these faces looking at you, and it's that's just too much to cope with. I think just taking them aside and choosing which person on the team should do that at what particular time, because some goals have got more of a psychological focus, others might have a more of a physical focus or a communication. So whichever the most appropriate discipline sometimes to go and have that conversation so that people feel they're being heard, that they are working forward. So as Liz said, we don't lose focus, but we keep working together. And I think it really helps when if the team are really effective, then it doesn't really matter who goes and talks to them about it.
I think when all else fails, go to the physio, because your problems are easily seen in your clients. They're visible. I always think it's the unseen that are the hardest to deal with.
No, I agree, Liz. Physios have an easy time of it because it's very tangible. You either can or you can't, or you need a bit of help or you don't. So I think, yeah, we do. And we do sometimes have an easier way forward with clients because they enjoy often the physical side. So yeah, I appreciate. Yeah, it's easier for me to talk about it sometimes.
No, I'm only just having a go at you.
I think it's a really good point, Sally, and it just made me think of a client I've worked with sort of over the last year or so who was, you know, choosing and to not engage as fully in MDT as I'd hoped they would, and you know, they found remote meetings particularly challenging and particularly intimidating. So I actually went to this person's home and almost had a pre-meeting before any MDT meeting on Zoom or any other platform, and then supported them through the meeting, but then also had a bit of a debrief session afterwards and kind of was almost that link sort of go-to person in between, so that the client didn't feel as intimidated or scared in their words of their whole team being in front of them, which was their opinion. I respected that. We didn't necessarily work to change that because that's the way they felt. It was quite an intimidating process for them, even though everybody was helping them. So it was, you know, sort of taking it from them to say, well, Simon can be the person who sort of represents me, but that's then their choice, and that made the whole process less anxiety provoking for this person, and it worked really well. I mean, it's not kind of probably the norm of how we would normally run it, because it was much more me being an advocate than potentially we needed to be in this instance, because they were, you know, able to engage despite their injuries. It was just a choice, but it actually worked really well. So I think it's just trying to be creative and
your role actually as a case manager to be that funnel, if you like, between a client as we're describing here, but key from what you're saying is making sure that their voice is heard. You know, exactly what are they saying, what is their viewpoint, and that's the key here in this situation, isn't it, to make sure that their point is actually got across.
Completely. And I was just thinking that kind of creativity and working around it, even though it might involve a little bit of extra expense at that stage, will save you a fortune further down the line. So it's allowing for that creativity and a bit of extra time to go out and have a one-to-one either before or after. And another thing we sometimes do in Cognivate, particularly in goal setting sessions, is that one of the therapists will go to the client's house in person and the other therapists will join via Zoom, but that puts one of you on side with the client and it can make it a slightly more supported experience. We found that works quite well sometimes.
That's great, thanks. Okay, I'm going to move on to another question, slightly different tack, if that's okay. Often our clients that we work with will have input from the NHS or social care, and often that will continue to work alongside the private providers such as yourselves who get involved. So just interested in if you could talk about briefly, if you can, your experiences of working alongside statutory services, and any positive experiences you've had with that and when it's worked well, and any of the challenges that we have working in essentially different models, and how you've maybe overcome some of those in the past.
I can say a few things about that. I think working alongside statutory services is absolutely vital, particularly for some of the very complex patients. And so seeking out information from statutory services is really, really important. Like, for example, I was writing a report on a case yesterday, and I had the case manager's notes, which were very helpful, but then we had some more reports come in from pediatrician and a multidisciplinary discharge report from a child development clinic. And this information was absolutely vital and so, important in writing a full report on this client, but it's not often always the case. And I would really like to potentially use this platform to say, even though we are independent, we don't have great access to our NHS colleagues by virtue of information transfer and even just pick up the phone moments. And so, I think the message is, please, if there is information that we can read on our clients, some of this is really vital, like in the work of feeding and swallowing. I want to know how many chest infections this child has had. I want to know about sleep apnea. I want to know about their struggles with constipation or just general health, because some of the things that we do, they have an impact on general health. They have an impact on fatigue. They have an impact on how someone functions in their environment, school, whatever. So I would like to say that relationship, I think, is really important and needs to be fostered. And it can be very difficult, and I don't know what everyone else feels, but it is so difficult to achieve that kind of cross-pollination of information. And it takes time to nurture those relationships with your NHS colleagues as well. So I don't know. I don't know what other people think, but it's important, I think.
Yeah, I'm with you, Liz, and I'm sure we all have seen this from both sides. We probably all either currently or have previously worked in NHS services and have now seen it from both sides. And I think one of the downsides sometimes of independent work is exactly what you were highlighting, Liz, is that lack of access to what is going on, that lack of shared communication. So any way we can enable that is critical. But I think it's also, when we can have co-working, it is brilliant, but we also need to keep in mind, I guess, the limits of the different systems. And NHS team, there are some wonderful NHS teams out there, absolutely brilliant, but they will not always have the time to join an MDT or to write an additional report at the time that we might need it to send back. So I think it's about keeping awareness of the different constraints on NHS and independent services and trying to meld them in a way that feels constructive.
And I think the other thing about that too is the important issues around safeguarding, because whether we have duties in terms of safeguarding and information across those teams, particularly in cases where there is a vulnerability of physical health or harm or whatnot. That information is really important. For example, I had a case where, mum was telling me that she had taken the child to the respiratory physician when in fact, actually the child hadn't been taken. It was a different story if you were on the other side with the NHS. So, I'm not accusing her of lying or anything, but I'm just saying, you get told things, but you can't always be certain that those facts are the actual facts. So I found that quite a vulnerable position to be in as an independent practitioner, but it was a massive learning point is all I can say.
And it's interesting. I mean, I'm just thinking of numerous examples of clients who I'm working with at the moment who are receiving some services from NHS and social care and some privately, and it's working as a team really, really well. And I think there can be some really positive experiences. But I think the issue around making sure communication between the whole team, and when that involves private and statutory, I think that often becomes more challenging. And I feel my role as the case manager becomes absolutely important there to make sure that if there's one contact at the NHS that it's me, and then I can be the link person to get information and to make sure that it's not just information coming from the NHS to the private team, but vice versa. And if the private team are going out potentially more frequently because they've got the funding to do so, and that needs to feed into the NHS team, and they need to get the information from us. I'm thinking of one particular client at the moment who that is working really well for, and we've got a really good relationship with a person in the NHS who is my contact person there, and they are then sharing information with the rest of their team, and it's working absolutely brilliantly. So I think that there can be examples where it works really well, but to me, that the case manager has to be taking the lead on that and taking responsibility to ensure that things are being shared on behalf of their client.
I think from my perspective, it's often just understanding, we've all worked in the NHS, but not everybody in the NHS has worked in an independent world, and it is a completely different world. And I've got quite a number of associates who do a bit of both, and just understanding how the different systems work, and not for the NHS team to feel threatened at all, because you mentioned litigation and they're worried and what that means, and for understanding we're just there for the client. And we all want to work together, and we want to avoid duplication, because if we can tap into NHS resources, I think it's brilliant. I've got a number of clients where I just collaborate with my colleague and we just decide who's doing what, and then it's easier for the client, because they don't feel that they've got to keep things from us, because we're working together, and that's all that really matters. So yeah, I think it's actually educating people about the rehab code and what that means, and that we're not trying to threaten anyone. We're just trying to work together to achieve somebody's goals and empower them, and talking a similar language as well, because the NHS are under such pressure, and knowing when we can step in and when we can help one another out.
I completely agree, Sally. I think that there is a sort of element of feeling under threat, as it were, and you're right. We've all probably been in that position, but they wouldn't necessarily understand, the place that we're coming from. And it comes back to this sort of transparency of communication again, is that talk to each other. And Simon, your key role in this, from an NHS or statutory services perspective, having a key person to communicate with can be really vital. And I'm just thinking of incidents of transitions and how helpful that is to have statutory services and NHS colleagues involved in transitional processes, because of course, what we know is that clients work best when we're able to support them through the whole process, rather than being a gap, or like Liz explained, sort of picking up but not knowing where you're picking up from. And sort of thinking, well, all of that lovely work that all of our colleagues have done already, it would be really great. And this comes back to the sharing of information, doesn't it? Right of the off. If we can have as much as we can, right from the off, then that makes everything helpful for all of us.
And I was just thinking, Simon, listening to you talk, I think these cases are where the role of the case manager is key, and probably really demanding, actually. We're working on a case at the moment where we have 3 separate teams involved with all therapies from all teams, and it's hugely complex to actually make that efficient and successful, and it requires really careful management from a case manager, so that you're not overlapping unhelpfully on goals, so that your remit is clear, and so that you can consider when it might be worth actually, exactly like Nicola says, transitioning from one team to another rather than having everyone involved simultaneously. So yeah, the case manager role is immense, I think, in those ones.
I'm just picking up on a question that we've had come through from the audience, which I think I might ask now, because I think it's relevant to the discussion we've had. From so Andy Laird has asked, and I'm kind of paraphrasing a little bit here, apologies Andy, but is there a danger of there being potentially too many professionals involved in an MDT, often resulting in clients feeling overwhelmed, getting different messages, different information, and how does that impact the overall outcome? And I guess I'll start off by answering yes. I think sometimes there is a risk that there are too many people involved, both when it's fully private or also when there's a mix of private and NHS funded therapy. And I think there's a risk of duplication of information. There's definitely a risk of clients being overwhelmed and not really sure who to go to ask the right question, or getting different opinions from people as well. I'm thinking of a client I worked with a couple of years ago who, we had a particular medical issue we needed to have investigated, and I think we ended up with 4 different opinions from a range of private and NHS surgeons who gave 4 very different opinions. And then for the client, that must be and it was extremely worrying and extremely confusing, and it was hard enough for me to unpick what was going on and the various reasons for the difference of opinion. So I think there is a risk to it, and I think it's a risk that I would say needs to be managed and would primarily fall to the case manager to try to minimize those risks. So I think we take that on as our responsibility. But happy to hear if anybody agrees or disagrees with me on that.
Yes, I think I agree actually, and I think I certainly agree on the grounds that with our patient, with particularly, the children, parents are going through quite a significant grief process, and they are, and rightly so, looking for the best of the best, or try this technique or try that technique, and so sometimes we come on board as the people commissioned to do a piece of work or extra work or something like this, but in that journey we find ourselves in a situation of there's not much more we can do, and I think that can sometimes be a problem in itself. So that takes quite a bit of sensitive discussion and extraction, because sometimes it is maybe better for the client to stick with their NHS team. It varies on case by case, but
I think, sorry to interrupt as well, Liz, I was thinking as well, sometimes it's the timing, because sometimes I've been on teams where there's so many people and the person is overwhelmed, and you could quite easily lose track. So I agree that sometimes you just need to get the timing right, and sometimes the focus changes. So the client Martha and I spoke about at the very beginning, in the start of his rehab process, the physical component was key, and now I've stepped right away. So because now it's more the management of the ongoing barrier to participation in the community is more the anxiety, whereas in the early days he couldn't even get out the front door. So I think sometimes it's just choosing, and again that's down to the case manager to try and coordinate and steer the team so that we don't overstretch the client and we lose their motivation and engagement altogether.
Yeah, I would entirely agree. So I think it's also I think as the case manager, when we meet the client for the first time, depending on how long post their injury or accident that we actually get involved, we can often come up with this amazing list of what we're going to do, and we're going to get X, Y, and Z sorted for you, and you're going to have this great MDT, and you're going to see the best surgeon possible. And sometimes, they've had very little input for whatever reasons, for long periods of time or short periods of time, doesn't really matter. But then we come in and can almost, I think there's a risk that the case manager can inadvertently overwhelm the client by trying to do too much too soon, and just their life just gets completely taken over by all this new team coming on board. So I think there's a real skill for the case manager to, in conjunction with their client, plan things at a pace and an intensity that is going to get the best possible outcome, definitely. But the client, has to feel that fits in with their life as well, depending on where they're up to in their life at the point that we come and sort of throw it up in the air, I guess, for want of a better term.
I think it's down to us as therapists, though, as well, to make sure, particularly, for us sort of very experienced therapists, we might be very confident to say, actually, we don't think there's a place for us here right now, or not right now, but maybe in the future. But for some therapists that may be less experienced, they might need a bit more support, particularly in our arena. They might need a bit more support with just being confident enough to say, actually, I don't think that I've got a role here right now, or I think actually someone else is better placed in this role. So I think it's equally as important for us as therapists to say when we don't think that we can be involved, and to very much have a conversation around that. And is it the right time? Because it's easy, isn't it, from a case management perspective, it's easy to try and pull in everyone, particularly when you see someone initially. But we need to think very carefully as therapists, is it the right time for that person?
Yeah, and I think when I first started as a case manager, Nicola, I did exactly that, because you're coming in, and I'd worked in the NHS and social care for years, and I'd come into this new world of case management, and you get told, you need to work in this way, and you can offer a certain intensity that I wasn't used to on the NHS, and I think it's taken me a long time and experience to learn that actually sometimes chucking everything at it from day one is the worst possible thing you can do. And actually, I think it takes a confident case manager supported by their MDT team to sometimes be pushing back on maybe some of those external pressures that are saying we must do everything really quickly, because the sooner you get your rehab, the better. And yes, that's true. We all know that. But actually, if you do too much too soon and the client doesn't achieve what they want to because they're exhausted or they just get fed up with rehab, then you've wasted that window. So I've learned that and quite happily put my hands up and say that's a very different approach I have now after many years being a case manager than it was on my first client that I saw many years ago.
I agree. I think we've all learned that, and I think everyone talking about timing, at the risk of sounding like a stuck record, I think the way round this is to stick with the goals again, because I think I completely agree with the person who asked the question that there's a real risk of having too many people involved. And normally, if you go back to what does this client want to achieve and what do they want to achieve first and what do they want to achieve second, then that normally tells you, well, who do we need now and who can take a back seat or just be consulting on this until later.
Yeah, that's great. Okay, thanks. I'm going to move on to a slightly different question. So most of our clients will have an ongoing litigation case where they will often be seen by a range of expert witnesses. Now, some of these reports may be disclosed to all parties during rehabilitation, not always, but sometimes, and therefore you may have access to these reports. I'm just interested if you could talk through your experiences of being a treating therapist in a team where expert witness reports and their recommendations are being shared with you and how you found that.
I can answer that one, but I'm sure others will have answers perhaps. Well, I think that firstly, it's very important for all involved in this information transfer to be aware of your roles, responsibilities, scope of practice, duty of care to the client. So we are, as treating clinicians, autonomous individuals. Therefore, when we engage in our assessment process and treatment process with our client, it is based on, a clinically sound assessment process and a clinical decision-making process, which exists in the client goal value framework. And it also exists in this sort of organism of the MDT. So there's a very, very live context in being a treating therapist. And so in a litigation process, you have a concurrent model. And so we don't really get involved with that, and we don't seek involvement really. That's not our job. We may be given information, but it's not, we're just treating clinicians. So we have to be very, very aware of our responsibilities and our duty of care. And I think that's really important. And so therein lies this sort of question about the engagement of the expert witness. So sometimes we may have a case manager, it's a Friday afternoon, and a case manager may just send an expert witness report to us on a Friday. And if you don't have experience in litigation, you'll probably think, oh my God, am I being investigated? So that is a real sort of horror story for someone who's not really used to dealing with medico-legal. And so they think, they might think their work is being studied very carefully. But in fact, it's very important for those treating clinicians to understand that the duty of the expert is not to treat the client, but to provide a report to assist in a litigation process and to assist the court. And there is obviously some CPR rules they have to abide by. But that in answering those instructions, there may be useful information. So there may be information of standardized tests, and standardized tests are tests that really shouldn't be they shouldn't be done redone in a 6-month window. So as a treating clinician, sometimes if I know that if mum or the case manager says, oh, an expert came along the other day and actually carried out the KELF assessment. And I'm thinking, oh, wow, I was going to do the KELF my client. And so it might be that you would approach the case manager and say, look, if you do get those results and it's possible, like, to avoid putting this client through this test again, it would be useful to have that information. So that has happened before. But I think the message is that we don't really need to see these reports to do our treating role. But I think the panel members would agree that it's very useful to have the expertise of, our learned experts to give us great, tips. But actually, I think we have to be aware that we can't expect that from them. Their role is different.
I've had good and bad experiences of sharing information. I personally quite like having the opportunity to discuss a case at the appropriate moment with an expert physio, because I think they have to go in on one window, one day, maybe another day, another time, but they don't necessarily get the wider picture. And as a treating clinician, as Liz said, you're working as part of an MDT, so the psychological influences, for instance, on somebody's physical performance, or their communication and how you have to build a rapport and get people to do things, or functionally, the influence of a different environment to the one that they're being assessed in by the expert, and the impact of that. So I think I welcome the opportunity to share information, understanding the fact that they are looking just from a pure physiotherapy role, but putting it all into context in the rehab process. So I've joined some assessments, and obviously I'm only going to answer what I'm asked, but I just find it a good thing to do. But that equally, I think for some, when you're early on in your career and you've only just started independent practice, it could be quite overwhelming to read a report and think, oh God, I don't agree with that, or I haven't done that. But I think, you need to seek support from your treating peers. So that's quite nice. In our team, we've got a number of very experienced physios, and we can ask one another for support. And I think that's invaluable. So yeah, I find it fascinating, but I don't want to be an expert.
I agree with what you said, Sally, about I really welcome information sharing whenever it's appropriate. I think it can be so helpful, and it can just avoid those cases where either as a treating therapist, you don't find out until the very end, for some reason, what was actually recommended. And then you think, oh, well, I could have communicated why, I could have given the clinical reasoning why I was doing this, had I known that there was something which looked different. Or vice versa from an expert side, when you're baffled by what someone's doing because it's just they're not melding. So I think that information sharing where it is appropriate is so helpful. And I agree with you, Sally. I've been invited to join an expert assessment on one occasion because I knew the client better and over a longer period of time, and it was really helpful from both sides. So I think it can be positive, but I completely agree with Liz that there are differences in role which need to be handled sensitively from yeah.
I think that just to pick up on the point that you made, Martha, about the sometimes you don't find out to the very end, and I think for less experienced therapists as well, they might feel very threatened by that, might feel very criticised, and particularly if there's a complete difference of opinion, when in actual fact, if you have that conversation, if you have the opportunity to discuss and what your experience as a day-to-day clinician, what you're seeing on a weekly basis with this client, as opposed to what the expert witness might have seen in a much shorter period of time. Of course, we're even as OTs, in my profession, we all work slightly differently. So of course there are going to be slightly differences of opinions, but for a treating clinician that then finds later on that actually the expert witness has a very different opinion, or why haven't you done that, or why haven't you done that, then actually that can cause a rub. So it's an interesting discussion.
I think Nicola, that's a really important thing that you raised. Is I have heard of colleagues where it has created quite a lot of tension. I think it brings us back to that first question. What was it again? the first one around what makes a good MDT. And this is all about the client and doing the best for the client. And so one has to ask themselves, is this information important to give the best treatment to this client? What is the purpose? And I do expert witness reports. And I think if my report was to be shared with the team, I'd like to know that was going to happen. Most times they're not for disclosure. So, and I've not actually, I don't even know if my report has been disclosed actually, but I don't know if it's ever happened. But if it was disclosed without my knowledge, I'd like to know about it.
I'm sure there are in-between points as well. So I've definitely had experiences where either it's been possible to disclose the whole report, and I've generally found that very helpful, but also other occasions where just a paragraph on the recommendations or something like that has been shared, which again it just enables you to have that awareness of what's going on in the bigger picture, so that you can reason what you've done. Or exactly like you said, Liz, with test results, that's something that very often comes up in neuropsychology as well. We will invalidate the assessment if we inadvertently retest someone within a window, and so it's really important that as a treating your clinician, you're aware of what has been done by other neuropsychologists, and equally as an expert, you need to be aware of if someone has very recently had an assessment by a treating clinician. And even if full reports can't be disclosed, you can often just disclose the names of the tests or perhaps the raw data, which saves the client repeating.
I also think I've been asked increasingly, and so our team, to do witness statements of fact, because there is no expert physio on the team. The litigation team, for whatever reason, there are lots of reasons, I know, but I think also, it's just gaining the confidence with that side of things as well. So I think that there's always more to learn. There's always more, different ways of looking at things, as Nicola was saying, and just understanding the process, the litigation process. I think that's really important for the treating team to see where they fit in, as Liz said, with the scope and understanding your duty and your role, and not worried about a difference of opinion. So I think we just all need to keep learning from one another, I suppose.
Yeah, and the final concluding remark on that is we're really reliant on our case manager to be really on it.
Exactly. That's exactly what I was going to say, Liz. I think we could have a whole several-hour long discussion, and I'm sure the solicitors watching would have an opinion around some of the risks around inadvertently disclosing information and the impact that can have on a litigation case as well. So I think they're very distinct roles. The treating therapist and the expert witness, they both have their place, and I think understanding that is critical. And the case manager needs to understand that around if they are being given information, fully understanding what that's being given to them for, and the impact of potentially inadvertently sharing that with people. And I think that there's a real risk of that. I was having a call with some solicitors this week who that was one of the points of discussion around how often they send information and then maybe don't say this is privileged, non-disclosed information, and a case manager inadvertently gives it to a treating therapist, and then that has a massive impact on the litigation process. So it's an interesting topic, and one maybe we'll host a further webinar on it one day. I think we could probably talk for hours on it, but I'm going to move you on if that's okay. And I'm interested in when you're working with case managers, what it is that you actually expect or need from them. I've asked you a lot of questions around what it is that makes a good MDT and how we manage that. I think the case manager has to take a lot of responsibility in ensuring they firstly pick the right MDT, whether that's individual therapists, organizations who provide the MDT. I think that's a really critical decision to make. But the case manager should ultimately be taking responsibility for when it's working well and making sure that it is working well as part of that team. And we've kind of touched on some of this already, but I'm just interested in anything else you as a treating therapist, things that you expect or need from your case manager to make sure that you're an effective team member.
I'll just pick up on this one. Just to say really that I think that, I've already spoken about sort of transparency and communication, but I think in terms of expectations from a therapist perspective, I think it's about shared expectations. So have that conversation, you know, as a treating therapist, have that conversation with the case manager right from the off. What are the expectations of each of us? You know, where do we both sit within this team? How do you want to be communicated? How would I like to be communicated to? And I think that, you know, we were all agreed that communication is key here, but I think also there is an element of reflecting on over communication or maybe over management. I think that there has to be an element of trust and transparency between a case manager and the very experienced clinician, and think about sort of how that is, you know, how that picture is managed really.
I think also the case manager, I've got some really positive and some not so positive experiences, but I think for me as well, overseeing my team of physios is understanding what's going on behind the scenes, because obviously the litigation process can have a real impact on what we can and can't do. And actually, once you understand that, you can just prioritize what input you can give and how you're going to proceed and be more efficient if that's what's required, because sometimes there are pressures behind the scenes that, well, I wouldn't want to be a case manager. But you've got so much, you're caught between, you know, between us all. And I think if we can have an understanding of what you're having to cope with and how you're trying to manage the whole situation, we can perhaps hopefully help you in a more productive way, because, you know, we're always keen to do more, but we just need to get that balanced right.
I agree, Sally, completely. And that's that kind of two-way discussion right at the beginning, isn't it? It's about what, you know, are there other influences that we need to be aware of within this situation? And because as a treating clinician, and we might be seeing someone on a weekly basis, you know, we're really involved in, we have the privilege of being really involved in their lives and in their families. And we need to know whether there are any sort of things to be aware of, and particularly from the case management perspective.
Yeah, I think my points are very similar. I was thinking the most important thing a good case manager can do is enable communication, whether it's amongst the treating team, but also bringing in those bits of communication that we may not know about and that help guide us. So I think it's being that conduit that keeps everyone connected and understanding what's going on. And I think the other kind of luxury that a case manager has sometimes is that helicopter view. So when we're very embedded in what we're doing, if the case manager is able to keep a helicopter view of the intervention as a whole and make sure that we're keeping on track with what's important to the client, with what's important for their progress, keeping an eye on sort of motivation or things slipping or drifting, then that's such a valuable role.
Yeah, I think I was just thinking it's, Sally, you made a point that you basically don't want to be a case manager. I sometimes think I would never want to be a treating therapist again. So I think that grass is always greener on the other side, isn't it? But I think it's about, I mean, some key words that are coming out for me are sort of trust and transparency around, you know, the whole reason as a case manager, I instruct a team of specialist treating therapists is because I need them to do a certain job, and if I instruct you to do it, then I expect you to be able to do that job, but then I need to let you get on and do the job as well. So I think, Nicola, your point around, I guess, you know, over case managing, I think is a real risk, and actually, but I think the positive thing, you know, spinning that back as the case manager, once I instruct and have a really good team in place, and if those lines of communication are open and working well, then my role and my job as a case manager becomes significantly easier and very low stress, because I've got a team that's working well, that are feeding me the information, the client's in the center of that, the client's happy, the client's engaged, and it makes my job as the case manager, you know, relatively straightforward, to be honest. The challenging ones are when people aren't talking, they're not trusting each other, there's a stepping of roles and boundaries aren't clear, and I think that's where things, in my experience, have gone wrong in the past. So I guess as a kind of a wrapping up point, I think that's a nice way to finish in terms of thinking. It's about, we all have our roles, we all have our expertise, and we've spent a lot of time developing that, and it's about using our skills to link in ultimately to get that best outcome from the client. And if we all do that well, then things aren't going to go wrong, and the client gets a great service, and hopefully makes a significant recovery and gets on with their life, which is, I think, as somebody said early on, if we can make ourselves redundant, that kind of means we've done our job, which is a strange way to run a business, really, but there you go. So on that note, I'd like to thank my panelists for joining me today. It's been a really interesting discussion. I think we could talk all day, but given it's a lunchtime webinar on a Friday, I think we'll try and keep it to the hour. So thank you very much for that. For the people watching, we have recorded the webinar, so it will be available on our website shortly and all the usual social media outlets. And if you've got any further follow-up questions, feel free to contact us at Ainscough Associates, and we can put those questions back out and respond to it. So thank you very much, and enjoy the rest of your Friday, everyone, and have a nice weekend.